This conference will now be recorded.
I don't know the metrics. I'm sorry. It just came back normal, so I just kind of ignored it. Went on to building my house. I'm sorry.
Sure.
But there is a metric. I think someone mentioned in the last call. Do you recall, Fan, what it was? I mean, the level you want to see or above?
Well, no, actually, my question was your last bone density test showing any osteopenia or osteoporosis?
No, it wasn't. It was all within the normal range, and the doctor said no cause for concern.
Okay, great. Paul, Frida, you need to talk tonight?
I think I'd like to wait for a night when we have more people, actually.
Okay.
Yeah.
We do have an additional person on the phone just joined us. Would you?
Yeah, it's David.
Hi, David.
Hey, good afternoon.
Hi, David. Welcome.
Well, thank you.
David, we're just finding out who would like to speak tonight. Do you have any issues you'd like to discuss?
Well, I was kind of thinking about last time I was chatting about somebody had expressed some concern about the gadolinium tracers that are used in MRIs and all that. And in the meantime, I met up with my cousin, who's a doctor, who had a bunch of scans, and I confirmed what I thought was correct, that he had done a chelation afterwards and taken a 24-hour urine afterwards, and the lab came back pretty normal, except for it spiked way out of normal range for gadolinium. So that's pretty, in my opinion, that's pretty conclusive evidence that particular modality is something that someone can avail themselves to if they're worried about gadolinium, toxicity or whatever. So just throwing that out there for contemplation.
So if I understood that correctly, you said you did have an accumulation of the gadolinium?
Yeah. It's EDTA.
They treated it with the EDTA.
Well, he treated himself. He went ahead and did it, So
yeah, and that did the job.
Yeah, well, I mean, he's thinking he's going to have to do a few more, but he did a 24-hour lab analysis of it, and it spiked out way high abnormal for gadolinium in his urine. So he was definitely pulling it out by doing that. So
what does EDTA do? Does it neutralize it or dilute it or what?
It's a preservative. It's also an anticoagulant. It binds to +2 charged +2. Well, it binds to anything that's positively charged, but it really likes things like lead, calcium, heavy metals in general. So now I know gadolinium is a +3, I think, but it's not quite as efficient as pulling out gadolinium. But it was originally it's in like every vacutainer of blood that you have drawn. Not everyone, but most of them have EDTA in the bottom. It binds to the calcium and it stops the clotting process by taking calcium out of the equation.
It's interesting. I wonder how it is. I wonder if they worry after giving you EDTA to remove the gadolinium. Are they worried that it's removing too much calcium and may cause bleeding?
I'm no expert on it, but I do know that it's been used for quite a few things over the years. First, originally used on people in the Navy in the 50s because they all had heavy lead poisoning due to painting big ships and stuff like that, and so it's got a pretty good track history for not really being a very dangerous compound, apparently. From what I know. Yeah.
Let me just bring Rick up to date here. We're just taking a census of who would like to speak tonight, Rick. And, well, we just heard from David on gadolinium, but Dennis Correa would also like to speak. And I just need to ask Les Shelderup if he would like to speak tonight.
No, thank you. I'm at the radiation, so I'm going to have to leave it at a moment's notice again. But I just wanted to get in on as much as I can. Thank you.
Okay, great.
So just tell us how you're doing, since we may lose you, Les. How's everything going there? How many under your belt?
It's over half. I forget. I've probably got 15, 12, 15, and still feeling fine. It's
Okay.
toward the end that they say you could start getting some ill effects, but so far I'm not feeling any. Thank you.
No, it's a pleasure. I mean, that's good. I guess that Peter is about to start probably within a couple of weeks, and I know he had a chat with what's his name, the fellow from Miami who's also at Scripps, not at Scripps, but he's with Rossi, and he's doing proton beam, but it isn't a recurrent situation. I've just lost his name for a second, but Paul something or the other, I think it is. But anyway, I mean, we're glad to hear you're doing well, and how are you enjoying Rochester, Minnesota?
Oh, it's been wet all the time that we've been here. That we saw the sun for about 2 minutes, I think. But other than that, it's fine. It's a nice city.
And how many sessions altogether?
There should be at least 25.
25. Okay.
Yeah, I think I will be doing my 14th tonight, I think.
Okay. No problems with your diet? It's not bothering your gut? You don't have any issues with your intestines?
No, nothing other than what I had before.
Okay. All right. Well, I don't know if that was guaranteed to get rid of whatever you had before, but as long as you don't have anything more, that's good.
Right.
Okay. All right. I'm gonna so just drop off whenever you can, and you can always listen to whatever we talk about on the recording. And I'm gonna hand it back to Len. Len, keep going, please.
Len, Carl Foreman has joined, and also Eric has joined.
Eric.
Yeah, so we definitely want to touch base with Eric, and Carl has his microphone turned off, but he is on the web.
Okay.
There he
So,
is. He's
Hi,
alive.
I'm here.
hi, Carl.
I can only stay for a half hour myself, so, but if you want to just talk quickly or.
Right now, we're just trying to find out who would like to speak. I assume you would like to speak tonight?
If I could do it for a few minutes and before I can leave in a half an hour, that'd be great.
Okay, we can accommodate that request and probably get to you first. And we also have Eric. Welcome, Eric.
Hello. Can you hear me?
Yes, we can. I assume you would like to speak tonight?
Yes.
And do you have restrictions on how long you can stay on the call?
No.
Okay, then.
Anytime.
Okay, great. Then I guess we can start with Carl, if okay with you, Rick.
Sure. Yeah. Please go ahead, Carl.
Okay, so earlier today I had my follow-up appointment with the head of the SIMCAP clinical trial that I am a participant in, Dr. Isaac Kim, at the Cancer Institute of New Jersey. The SIMCAP trial in which I am participating is a trial that is determining the effectiveness of having a radical robotic prostatectomy in addition to standard of care, which is the hormone therapy. I am scheduled for the operation on November 14th. I've had a number of discussions with Rick, more so, and to a certain extent with Len as well. And the purpose of my meeting today was to hopefully get some semblance of quality of information to help me decide whether to continue in the trial and have the procedure or not. And I was a bit disappointed with the meeting to the extent that I thought I would get clarity, but the Dr. Kim gave a lot of detail to me about the surgical procedure itself, and that it appeared to be more extensive than I had originally believed it would be, and that the level of incontinence, as you and I, Rick, had spoken about, where I was told that after 1 year, the percentage was less than 2% of those, approximately 1,700 procedures that Dr. Kim has performed, less than 2%. And then he clarified, he said, well, that's everybody, and that's not necessarily those who we operated on, and however many those were, he didn't quantify of those in the metastatic situation. And he did say that my degree of incontinence will probably be in the 30% range. That it's a more involved surgery than, again, I had believed it would be. He said typically a surgical procedure like this would take about 2 hours. Mine would probably be 4 to 6 hours. And that there would be some invasiveness into the bladder. And he said that, and we talked about the need for a sphincter at some point in the future, and or the, I forget the other term, relating to the bladder. But he didn't say that I wouldn't necessarily have it. It's a possibility. And originally I didn't think that was the case. I was looking positively that I would get through it without any substantial side effects. So that's now not true, as Rick had been telling me for some time, that was probably going to happen. And so, as I said, I'm a bit disappointed about the meeting. I also met with the oncologist. So the good news on this meeting is that my latest blood work as of last Friday, with me continuing on the daily dose of Zytiga with prednisone, the Eligard shot that I had 2.5 months ago, and the Xgeva shot, which I had another shot today of Xgeva, so that was my second one. My PSA is now down to 0.2. The last blood test was a month ago, was 0.32, so now it's down to 0.2. And the alkaline phosphatase is also down from 90 last month to 60, so well within the normal range. And the oncologist pretty much says, well, look, you're in remission right now. Oh, that's nice to hear. Nobody had said that to me previously. And so that's on that side of the equation. My wife was in the meeting today with both doctors, and after talking with Dr. Kim about the surgical procedure, I was a bit more reticent about continuing, but my wife said, I don't think you have a choice. I think you have to do this. And Dr. Kim was, he said, look, I can't promise anything, but the whole purpose of the trial is that at some point that he believes it could potentially be curative for those with metastatic cancer. And he says he's one of the few surgeons has has the expertise to be able to minimize potential side effects with the procedure. And so my wife says to me, you know, I have incontinence from time to time. I have a pad, and that's really, I guess my question is that all incontinence is? To the extent that, okay, I'll have to wear a pad, aka diaper, and when it's wet, it has to be changed. And I'm just wondering, well, is that really that bad? Because Dr. Kim had said, look, at some point in the future, the Zytiga is going to stop working. It's probably going to be somewhere around 2 years from now, and that your window of opportunity going into the future, it's less clear that the surgical procedure would be as helpful to you as it would be now, early in the process, as being newly diagnosed within the past 3 months. So that's the short answer. So I turn it back to you guys.
Well, I have some thoughts, but Len, you go first.
Okay, I have a feeling Rick's thoughts and mine are going to be similar. First, could you, for the sake of the rest of us on the call, Carl, could you remind us of your Gleason score and the extent of your metastases and lymph node involvement, so we know what we're dealing with?
Sure. As far as lymph node involvement, the only thing that I've had so far that shows anything relating to the lymph nodes was the digital PET scan that I had with sodium fluoride, and the radiologist has said he didn't see anything in the lymph nodes. Dr. Kim yet today said, well, you know, we are going to remove some lymph nodes during the procedure to make sure that, you know, you're clean. At this point, the only thing that I've been told I have are lesions in the pelvic bone. There was upwards of 5 or less. I believe there's probably just 3, which will make me oligometastatic, I think is the term. And that they are clearly shrinking as a result of the Xgeva and the Zytiga and the hormone therapy as a result of the alkaline phosphatase being lowered a great deal. And my Gleason score, I had my prostate biopsy on June 8th. The original pathology report out of Capitol Health in Pennington, New Jersey, showed a Gleason score of 7.8. There was a second opinion that my urologist sent on to Dr. Epstein at Johns Hopkins, and that came back with a score of 9.10. The day before the biopsy, my PSA was 20, and as I said, as of last Friday, it's now 0.2.
Okay, so I know originally when we met you in Los Angeles at the conference, it seemed that quality of life was very important to you, and I'm wondering why you're now more willing to accept incontinence as a side effect when the likelihood of incontinence may very well be lower than that 30% that your urologist is talking about with radiation.
Interesting enough, Dr. Kim, when we talked about radiation, he said in my specific diagnosis and condition that radiation is not an option.
Why?
Because of it being possibly located elsewhere. Radiation is confined. Yes, we know it's in the pelvis. There are some lesions, but he does not believe that radiation is an option for them.
Well, I would want to drill down on with him significantly, because look, the concept of debulking, I think most of the guys on this call, if they had the opportunity to debulk today in 2018, would probably do it. If they were diagnosed today and they were offered the opportunity to debulk their primary tumor, I think most of them would say, okay, let's go, let's debulk. Now, a lot of the guys have not debulked because it wasn't spoken about as frequently 3 or 4 years ago or 5 years ago. So the question, as we've said all the way along, is how are you going to debulk? You can debulk either with surgery, or alternatively, you can debulk with radiation. And if you were to do the radiation, you would be probably radiating the whole pelvic girdle, not just the primary. Why? Because we know you've got disease there, because it's actually oligometastatic, although Len and his Italian would like to call it oleometastatic, but we're going to call it oligometastatic. Is that okay, Len?
That's perfectly fine.
Okay. So it's oligometastatic is the term. Oligo means few. So to me, I'm worried that Dr. Kim's selling you a bit of a bill of goods here. I mean, we can't give you the medical advice, but we can tell you what sounds fishy. It sounds fishy that he's going to cure you. He'd like to cure you, but I don't think that there's anything out there today that is known to cure metastatic prostate cancer. Can we get you a durable remission? Hopefully we can, if we treat you right. But it
he clearly didn't focus too much upon the curative. He says, I hesitate to say this, but that's really my eventual hope that this will be curative, not only for me, but for whoever has the procedure going on into the future.
Okay, well, I think that's good that he didn't focus on it, because I doubt that he could accomplish it. But what I think he could do is give you a better chance of a longer remission with the surgery. But I also think that you could probably do that by radiating the primary and also by treating extensively the pelvic girdle. Again, this isn't medical advice, but it's what I would do, because I've seen other guys who have gotten some relief that way. And as far as the side effects are concerned, they're probably, my guess is they're going to be significantly less than the surgery would be. The surgery is going to be extensive. I mean, I'm a little concerned when he says that he's going to get into your bladder. I mean, yes, to some extent your bladder is impacted because they got to cut the urethra, but I'm not sure what he means when he says get into the bladder. Do you have, is there any evidence of metastasis in the bladder?
No, and actually the oncologist ordered for me, and I am scheduled next week to have a follow-up bone scan as well as a CT scan of the pelvis and abdomen.
Okay. Well, I mean, I don't know if there's anything more that he wants to do with the bladder than would normally be done in an operation like this, but these operations are generally pretty lengthy. I mean, they're oftentimes a 4-hour operation. It's really big surgery. It's big, major surgery. And before I committed to that surgery, I'd be wanting to talk to a really good radiation oncologist, somebody like Zalewski, or maybe our boy, what's his name, with the German name at Memorial Sloan Kettering, Len.
Boris Mueller?
Boris Mueller, yeah.
Yeah, and actually, Carl's in New Jersey, right? So Boris recently transferred to New Jersey, the MSK office in New Jersey.
Yeah.
Oh, is that the Baskin Ridge office? Because there's 3 now in New Jersey.
Yeah, I believe it was Baskin Ridge. Let me see if I can. Oh, no, I don't have it in my email. It was a letter I received from him.
What's his last name?
Mueller. Mueller.
Okay. Well, just to let you know, Rick, at your suggestion, I did reach out to Sloan Kettering to try and get an appointment with Beth Rathkoff. And there's just so much red tape. It's unbelievable. I've made several phone calls. Dr. Zhao was the first person I saw in Basking Ridge. And for me to, as they call it, change doctors is like, going through hoops. And it's very frustrating that they just don't get back to me. I leave several messages. I speak to people. I said, look, this is really, time is of the essence. I really want to see Dr. Rathkoff in New York. Okay, we'll get back to you. And then I hear nothing.
Okay, they have, I'm pretty sure, Len may know better than I do, but I'm pretty sure that they have a patient ombudsman or a patient navigator. And that's who you have to get hold of.
Yeah.
So you need to check and see, you need to just call and say, look, I'm a patient. I'm not happy with what's going with the way that my care is being handled. Can I please speak to either the patient navigator or the patient ombudsman? And they'll ask you what area, and you've got to get into it with them.
Okay.
Might be considered patient advocate as well.
Yeah, okay, I don't know. I mean, maybe if you looked online, I mean, I'll look whilst Len's talking to you, but I'm pretty certain I've seen somewhere that they do have somebody of that nature to work with patients at Memorial Sloan Kettering.
Yeah, Carl.
Yeah, I hate to add more confusion to them because I've already asked for an appointment with Rathkoff, and if I go back to say, okay, well, now I want to work with Boris Mueller, then they'll say, well, what happened to Rathkoff?
Well, no. The two are not mutually exclusive. You
Okay.
need to see both of them.
Rathkoff is a medical oncologist. I'm not sure you want to see an oncologist just yet. First, you would probably want to talk to a radiation oncologist because you want to decide what your primary treatment will be, which will either for debulking, which will either be surgery or radiation. And then the medical oncologist like Rathkoff would come in after you have your primary treatment.
Well, but Len, I think the reason why we suggested Rathkoff is because to get a better handle on the whole concept of whether it's worth debulking the primary.
Oh, okay.
With metastatic cancer.
Okay.
And I think that if it were me, Carl, I would definitely be wanting to talk to Dana Rathkoff and get her view on debulking the primary for with metastatic cancer. And I'd also want to talk to a really good radiation oncologist. And we're suggesting Muller, but it could be Zalewski, who's the head of the department, and ask them about debulking the primary with radiation and pelvic and their view of pelvic girdle radiation for somebody like yourself. And Carl, are you clear with us that these two are complementary consults, not one or the other?
Okay.
You need, and that's why I think. I'm trying to see if there's anything on the for the ombudsman. It's not giving me any result. But again, I think if you call them and talk to them, I wish I could give you a better handle. Len, in your experience at Memorial Sloan Kettering, how, if you wanted to change your doc, how would you go about doing it? Because this was actually an issue that you had to address, wasn't it? Or you thought about addressing?
Well, the way I approached it was I wasn't happy with my medical oncologist at Sloan Kettering, and I went for a second opinion outside of Sloan Kettering. I went to Mount Sinai in the city. So I avoided that potential conflict where you're trying to move from one oncologist within MSK to another, which I have a feeling they're not eager to do that, to have you
They're
do that.
not.
Yeah,
They're not.
clearly.
I agree, but you know it can be done. And like I say, I think I would probably be trying to find the patient navigator. I mean, anybody else have any ideas on the call about trying to switch your care at a hospital like this? Trying to switch your doctor?
I could pipe in on that. So this is David. I had pretty much that same experience where I had one doc at Seattle Cancer Care Alliance, and I was wanting to get consults with other physicians in the group, in the prostate cancer group, and they just didn't want to let me do it. It was, considered taboo almost. So I basically had to contact the ombudsman and say, look, I'm just not happy with, communications that's going on with my current MO. And they went ahead and did it, but there was a lot of inertia for that kind of thing, so.
Yeah, I mean, thank you, David. I mean, I think it's particularly true at these centers of excellence. They don't like to do it, but they will do it. And I think the way to do it, as David said, is you've got to get hold of the ombudsman and say, look, this is who I want to be seeing. This is who I was assigned to begin with. I'm not thrilled about the care. And this is who I want to see. I'd like to get an appointment. I need an appointment quickly, and I also need an appointment with a radiation oncologist, if possible, Dr. Muller, because I'm scheduled for surgery. I don't know if I want to proceed. I don't know if I want to proceed with the protocol that I'm being lined up for.
Right.
Hey, Rick.
Yes.
So just want to pipe in something here. I can kind of relate to Carl's position, but I'm just wondering, since he's high risk, Gleason somewhere between 7 and 10, did he get, or has he sought out any of the genetic modalities that are available for inquiry? Because it might make a big difference if you're going to get radiation and you have BRCA gene or you have ATM gene, that may kind of steer you away from it, because it sure did for me.
Yeah, go ahead.
Interesting you say that, because yes, I've been pursuing the genetic angle, so to speak, for the past several weeks. I was on the phone today actually with Foundation Medicine. The original sample that they got from my biopsy was not sufficient for them to perform a test, and I asked the Cancer Institute, Rutgers Cancer Institute, to follow up and get an additional sample. They acknowledge that they have just received a second sample from the original pathology department, and that they anticipate, if all goes well, that by the 22nd of the month I should have a report. In addition, from my second opinion at Mount Sinai with Dr. Mark Stein last week, he was the first to recommend to me that I pursue the color genetic test, which is a matter of spitting into a tube, and that was done. It's not as extensive as Foundation Medicine. It's $30 versus $320. It's $99 versus $6,000 for the Foundation Medicine. Although Foundation Medicine did say to me I qualify for their low-income version, and that I would get a 90% discount, so it would only cost me $580. Well, okay, I can deal with that. So that is being pursued. But Dr. Kim, in asking him about these genetic tests, and I wrote down a whole list. There are other tests. There's the OncoDX, is Polaris. There's several other tests. And he says, all of those tests are not for you. You're already metastatic. They have nothing to do with your situation. So.
That's just not true. That is absolutely not true.
Yeah, if a doctor that was on my medical team said that to me, it would give me great concern, because there's a whole bunch of reasons it could be very relevant. It could be very relevant, as David points out, because if you have the ATM, David will attest, if you have a mutation in the BRCA or the ATM pathway, it can cause problems with radiation, as it did for Professor Bill and potentially for David. It can identify a precision medicine that you might be a good candidate for, and that might change your strategy. And I don't get these doctors. I mean, does this guy Kim have his head buried in the sand?
He's a surgeon, right?
Yeah, he's a surgical oncologist. Yes.
Yeah, but whether he's a surgeon or not, I mean, you keep up to some extent with the literature, and he knows about precision medicine.
Right. Well, clearly, I'm still pursuing that route as well.
You're doing the right things, Carl. We've just got to, yeah.
I was just going to say something. So just kind of to relate to how I approach that is the reason why you need the color test and not the other one you're talking about is because the color test is looking for germline defects. It's not focused on your tumor. So it has a different sort of significance in terms of, things you might do. But the other thing I was going to say is, and this is I think worth asking, is because I was real concerned about the incontinence issue as well. I mean, it's a pretty heavy duty procedure, and I'm still wearing a pad, but it's only been 2 months, so I got my fingers crossed. But it was a really extensive surgery, and the thing that I discovered, I came across was and it's just kind of left field, but it might be worth asking about. It's called the Retzi procedure. It's fairly new. It's been around for a while, but it's not widely practiced. But it has a really high mark for preservation of urinary continence, and it apparently can be done in the high risk category of this disease. So something to think about.
What is it, David? What is the Retzi procedure?
Well, if I was a surgeon, I could answer that for you, but I guess it has something to do with the way they go in and cut it out. And I have no friggin' idea what it is, but, I mentioned it to my guy, before we did the surgery. He was aware of it, and he said, "No, I'm not going to do that." Probably because he's never done it before, but he said, "I'm going to do my best to make sure you have urinary continence. Trust me, or whatever." So I just went ahead and went for it. But
so
well, I'm sorry, I only have another 2 minutes. Are any of you going to be in Virginia this weekend? There's a one-day conference at Virginia Beach.
Yeah.
No. Okay.
Rich Jackson will be there, and like I said, I mean, just don't overload yourself with information. You've got enough stuff going on that I'm really concerned that you're going to come out of there and then you're going to have a whole bunch of other stuff that you're going to have to, is going to be running around in your mind. So I just want to give you that heads up. I don't change my position on there, particularly since you're going to hear some pretty outlying doctors like Snuffy, and then you're going to be thinking, oh well, Snuffy says this, Snuffy says that, and while some of what Snuffy says is very good, and a lot of the practice that we're doing today is really attributable to him blazing the trail, he also has some ideas that are pretty far out, and you need to be really focused right now.
Okay. Yeah. Well.
I mean, for example, if you get hold of a navigator tomorrow and somebody says we can give you an appointment on Friday or Saturday with one of these docs, I mean, that's where your attention has to be.
Oh yeah, I'll be on the phone tomorrow.
Yeah. So I just really want to get you focused. I mean, this is all. I just want to go back very quickly to this genomic thing. We talked about it last time. We talked about the color test with you last time. But, the germline is what you've inherited, and you have some cancer in your family. So the germline is what you might have inherited. The foundation medicine test is is what is already in your cancer. And since your cancer has really seen very little treatment, you're probably less likely to see the mutations there than you might see mutations in your germline, which you inherited. Because a lot of these mutations occur in response to treatment, because the cancer is trying to survive. So it mutates in order to maintain to preserve its survival. At least that's my understanding of how some of these mutations come about. Not all of them. I don't know, Len, you want to comment on that?
Before Carl leaves, I wanted to make sure he got this message. The caution about getting radiation if you have a BRCA mutation is only relevant to germline BRCA mutation.
Oh, thank you.
That can be detected with a blood test. You don't have to worry about whether or not your biopsy sample was big enough or contaminated,
right.
Or whatever. It's a simple blood test.
Or spit test. Or spit test.
Right.
Yes, yes, that's true too. But if you have what they call a somatic or tumor mutation that Rick was just talking about, then radiation is not an issue for you.
Okay.
But that's all you need to find out. Do you have the BRCA germline mutation? And so, yeah, I agree with Rick. There are a few things that your surgeon has said that sound like a sales pitch. One is the idea that he can cure you with oligometastatic disease. I need a cross. Sorry. And the other is that all of a sudden he went from 2% incontinence to 30%. You definitely need another opinion.
Well, since we're at that 30% number, he asked the one and only other time we met with him, he did say at that first meeting that it was 30%. So when I got that 2% number was from his staff, from the statistics that they maintain. And yes, overall, it is 2% for everyone, but not for the metastatic people like me and us. So, all right. Well, to be continued. I appreciate it. I got to run. Thank you very much. We'll talk soon.
Keep us posted.
Yes. Thank you. Bye.
Go ahead, Len.
Okay. So we also wanted to hear from Dennis Correa about.
Why don't you let Eric go first?
Oh, I'm sorry. Yeah, I forgot about Eric. Yeah, why don't you go, Eric? There he is. Hey, you look good.
Oh, look at that hair, man. So fill it in. All right. Anything tied back behind or not?
No, not enough there yet.
Oh, okay. Okay, just checking.
Good stylist.
So there may be some noise in the background here. I'll try to work through it. So today I had my third session of Keytruda. The likelihood of Keytruda actually working is fairly low, but we're working on moving to something else sometime. They originally said that they would do some tests after the third round. Now they want to wait till the sixth round. I'm going to push that one. I've lost 45 pounds. I can't stand to lose much more. So doing everything I can to go ahead.
Is that because you have no appetite?
No appetite, nausea. Even when I feel okay, I eat, and I get full after 3 or 4 bites and can't eat anymore.
Okay.
We have our latest
Insurance.
But even that, Day before yesterday, I drank an Ensure and immediately threw it up. So, yeah, I don't know. You know, it's really not going well. So, yeah, you know, I don't know what else to say. I'm still saying I'm having to get hydration 3 times a week now. It helps with the appetite a little bit, but obviously not with the weight loss. You know, mostly right now I'm just working on trying to get some weight back on and, you know, eat, drink, whatever I can to get some calories and some protein into me. So I don't have to say, you know.
Eric, do you get your IV fluids at home, or you have to go into the hospital?
I go into Berkeley, yeah. I could do it at home, and I have to do it myself. I decided I didn't want to do that.
What about, did they discuss parenteral nutrition at all? Where they would give you nutrients through IV, not just salts, but actual proteins, amino acids.
There are many dangers with that. We've discussed it with the oncologist, and he highly recommends against it. Tend to get fungal infections. If you already have a compromised immune system, it's really not a very good thing to do. If you're healthy, then you can do it. It's kind of contradictory, but yeah, we brought that up, and they said it's really not an option. You know, unless I was starving to death and it was the only thing left. Yeah, it's, you know, we can't really go there. In theory, you know, if I drink enough of the Ensure, you know, they have the high protein version, and you know, if I can keep that down, I'm trying to do 2 a day. But you know, so far I've been in the hospital since I last talked to you guys. I've been in the hospital 3 times. So,
do you try sipping the Ensure, just 1 sip at a time, put it down, come back to it in 20 minutes, rather than gulp down the whole thing?
Rather than gulp it down, yeah. No, when I threw it up, it was over an hour that I was drinking it, and about a half an hour later it came up. So, yeah, it's not. I've tried many different methods. You know, the foods that used to work don't work anymore. About the best thing I can do is some broth. I do have some good news, though.
Go ahead.
My granddaughter, second granddaughter, born 2 days ago.
Oh, congratulations.
7 ounces.
Congratulations. Bravo.
Oh, that's great news. That is good news. Eric, you were hospitalized 3 times. Was it for dehydration?
Vomiting and nausea, so I didn't eat for several days. So I was just getting so weak that I had to go in and you know, get rehydrated and fed and whatever in the hospital.
And you say that they weren't going to do any testing between the 1st and the 6th? Ah, okay. Cutie.
I'm sorry, say it again?
You said that they're not going to do any testing between the 1st and the 6th, but now you're pushing after 3. I mean, so you haven't had your PSA tested since you started?
Oh, no. PSA has been tested. It's spiraling. 360.
So 360. Okay.
Yeah, 2 months ago it was 120.
Yeah.
So yeah, no, I'm getting the blood test. It's just getting a bone scan or something like that that
Right.
we're talking about.
Right.
My last scan was in August.
Okay.
So that's the one that showed that it spread to the pelvis and the ribs and more in the neck. It's in C4 now. Taken over.
Yeah. What other treatments is Agarwal thinking about? You said he's got some things up his sleeve. What is he thinking about?
Well, I haven't met with him. I met with his PA today. I meet with him next time. And the PA didn't know much. So I could probably send Dr. Agarwal a message and ask him, but at this point, he hasn't specifically come up with anything. He's got, he's in charge of all the phase 1 trials, and I'm just presuming he'll come up with something.
Mm-hmm. So nothing's been discussed specifically?
That's correct.
Are they managing your pain well?
Yeah, I was going to ask.
Yeah, the pain's being managed pretty well. BJ's working on that. BJ's also working on the nausea and vomiting. And
Where can we put this somewhere or something?
Eric, this is Jake. Did you say they were going to give you 3 treatments of Keytruda, but now they're going to do 6? Did you say?
6 before they do tests. I had the 3rd one today, and I was presuming that sometime in the next couple of weeks I was going to get a bone scan, but they said it's too soon.
Okay. Do they think Keytruda is working? I mean, they would.
No.
They don't think it's working, but they're still going to continue with it.
Yep.
That's interesting.
Yeah. I will be sending Agarwal a note about that, saying, if we think it's not working, why are we continuing?
Right. Yeah. That's what makes me wonder. Another question: since you're having a lot of diarrhea or vomiting, do you take something for like Gatorade or something to replace your electrolytes? Does that help?
Yes.
Does that help?
Yeah, it does help when I take it down. I have some powdered electrolyte stuff I use, and then I also drink Gatorade.
Okay, and you can keep that down.
Yeah, that seems to be okay. Yeah, I have these bouts of nausea where it's just, for some reason, my time seems to be 3 a.m. is when I get sick. So.
Oh goodness.
I wonder if it's.
So of course.
I'm sorry. I was just gonna say, I wonder if it's because your stomach is empty at that time. I wonder if you might want to, if it would help to take a small, a very small dose of meal or something.
Yeah, I was thinking that, it could be that it's, because I'm sleeping and it's long enough that I've now gotten dehydrated again.
And your stomach's empty.
Maybe that's what's going on. Yeah. So wake myself up at 2 and drink a glass of Gatorade,
Might be worth a try. Can't hurt, right?
Yeah. I'm sorry?
It can't hurt.
Oh, right, exactly.
Yeah.
Yeah, try this, try that. Oh, you like the latest thing they gave me? Composine suppositories.
Oy.
Is that to combat nausea?
Right. So if I'm so sick that I can't hold down a pill, then we start from the other end.
Have you tried any type of CBD mixes for your nausea?
I used some liquid drops under the tongue stuff.
Yeah.
It made me narcoleptic. I would just be sitting there and I'd fall asleep just sitting in my chair.
Well, I mean, I really maybe talk to BJ about this, but I just know a lot of guys that have used vaporizers and had good luck. And maybe if you went down to, what's the big pharmacy in Oakland called?
The big marijuana one. Yeah, I forget. But anyway.
You know what I mean, though.
Yeah, yeah.
I mean, if you ran down there, I mean, you have a license, a prescription, right? You have a certification.
Oh, yeah. I have a vaporizer too.
And you have a vaporizer. You might want to run down there and see if they can give you anything specifically for the nausea. Give you some, give you a CBD and tell them what happened when you took the liquid under the
Oil
tongue.
drops. Yeah.
And go in and talk to them, because those guys are pretty good. They know what they're doing, and they may have some sort of combination for you that you could vape, and it might help you with the nausea, because that's one of the things that it definitely helps with.
Oh, yeah. Yeah, when I was back on the docetaxel days, I had some CBD gummy bears, and it really helped a lot. It cleared up all the nausea and the sickness feeling, and I could eat and everything. But of the 6 doses, next 2 I tried after that, it didn't help. So I don't know if it was inconsistent.
I was just going to say, if we can get you relief for just even a short time and some appetite, and I mean, I don't think you got anything to lose with that. If I was there, I'd be driving over from Mill Valley. I'd take you down there tomorrow morning, man, I tell you.
Uh-huh.
Do the composite suppositories, do they help with the nausea?
I'm sorry?
Do the composite?
Oh, no, I haven't. I just got them this afternoon.
Okay.
Haven't tried them yet.
I just looked it up because it is for nausea and right?
Yeah.
And vomiting.
Yeah.
Okay. Well,
let's hope that works.
Yeah, let's hope it works.
Yeah. A month supply, my copay was $100 for a month supply.
Not cheap.
Okay. Well, I'd like to see you try, those gummy bears again, or a vape or something like that, and see if you can get any relief out of it.
Sure enough.
Anybody else would like to talk to Eric and chip in and on any subject, from his granddaughter to CBD gummy bears to shoving some composine up his tuchus?
What's your granddaughter's name, Eric?
Josephine Elizabeth Bookbinder.
Okay.
Very nice.
She is a cutie, that's for sure.
Okay.
I'm sorry?
She is a cutie.
Oh, for sure. Yeah, she sure is. I actually haven't seen her in person yet. We're working on driving up there this afternoon, although it's with commute traffic, and commute traffic's about an hour and a half drive, so I don't know if I'm up for that or not. They're in Suisun City next to Fairfield.
Oh, yeah. I know what you mean.
Yeah, normal traffic, it's about 45 minutes. Commute, it's about double that.
Well, we'll go in the morning and go via Oakland and then go on up there afterwards.
Yeah, makes sense, yeah.
It does make sense. Leave about 10 o'clock, go via Oakland. It's almost on the way, and then you'll be there in a heartbeat.
Yeah. Yeah, so far I've been going to a place in Berkeley called the Berkeley Patients Group.
Mm-hmm.
But, since it's not very effective to me, I haven't gone very often.
I mean, I don't know. I mean, maybe they're just as good, but I do know that one in Oakland has a really good reputation. And they have a lot of different blends, which is really what it's about. And I am going to, the weirdest thing happened to me last week. but it turns out that somebody I know, not very well, I've met her 2 or 3 times here. Her daughter came to live with her. Her daughter just had a little baby. Her daughter's trained in Chinese medicine and acupuncture, and she's starting a practice. And so I reached out to her in case she knew anybody that could benefit from our groups. And it turns out that this woman, this acupuncturist, treated me 10 years ago in Mill Valley, which is really weird. I only raise it because I'm going to talk to her tomorrow, and I'll pick her brain on if she's got any thoughts for you on the nausea stuff. And you know, I don't know. I kind of feel like some of the complementary medicine protocols, like CBD or possibly acupuncture, some of the other things may be helpful for nausea and appetite. So if I come up with anything when I talk to her, I'll let you know. But I will say that I know you don't feel great, but you look a heck of a lot better than last time we saw you on you really do. So I'm pleased to say that. I know you don't feel great, but I just want to tell you, so hang in. Anybody else would like to say anything to Eric? Anybody else have any thoughts on controlling nausea or stimulating appetite?
So your crowd seems to have shrunk. What's going on?
I don't know. We've been low for the last month or 2, but it goes in phases, and then all of a sudden there'll be a whole bunch of people. But we've been settling in around 12 to 15, which is good because it's an easier group and everybody has time. All
right. Well, I'm feeling sick right now, so I'm going to have to sign off, guys.
Okay.
All right, take care, Eric. Thank you for sharing.
We're sending our prayers and thoughts, and let me know how you do if you find some sort of a solution, and I'll tell you. Okay.
Good to see you, Eric.
Okay, bye.
Bye.
Rick, I only had one more volunteer for tonight's discussion, Dennis Correa. Is there anyone else who would like to speak besides Dennis? Okay.
Len?
Hello?
Yeah, Len?
Yes,
Oh,
Paul.
yeah, Len. John Appler speaking. I was just curious for Rick's thoughts about, Dr. Agarwal and Eric's case, and, if maybe we should be encouraging to see someone else in addition, or I didn't want to speak up while Eric was on the phone, but I'm curious about Rick's view of Dr. Agarwal's care in Eric's case.
Well, Agarwal has a really long history with Eric. It took us a long time to convince Eric to go to UCSF because he was at Sutter for much of the beginning of his care. And I think that there's a very good relationship that exists between Agarwal and Eric. I also think that the oncologists at UCSF have kind of been depleted. So, Chuck's not there anymore. One Kim has left and gone over to Kaiser. I'm trying to think who else. So some of our go-to, and Larry Fong is not seeing patients. There's 3 right there. So the question is, who would you refer to? I'm not a big fan of. I would not refer somebody to what's her name, the woman. I wanted to say June Chan. It's not June Chan. I'll tell you in a second. But Terry Friedlander. But I think that he's good. I mean, he knows he's on top of all of the trials. He knows what he's doing. And he'll get back to him. He's also got BJ in his corner. So if he runs across any issues, BJ Miller can cut through stuff for him. So, John, I mean, for me, I would tend to stick with Rahul.
Okay, that's good to hear. Thanks for your feedback on that. It seemed like Eric should not be meeting with the MA or the PA. He, his situation is so serious. It seems like he should have better access. But maybe that's just the current state of staffing there.
Well, I mean, I don't think it's so much the current state of staff as it is that's what happens at UCSF a lot of times when you get treated. If your doctor isn't there, you get to see the nurse practitioner or the assistant, and the doctors aren't always there, and it's a big issue. And it's not just Eric. I mean, that happens a lot, and that's why I always tell people, be proactive. Don't, especially if you're going to be making treatment decisions, make sure you get the doc.
Yes.
It's always worth calling at a time. The doctor whose name I was trying to remember before was Amy Lynn, and she's not somebody that I would recommend to anyone. But
okay.
For various reasons I don't want to get into on this call right now. But yeah, I mean, I hear you. But it's not the first time and it won't be the last time that you go for an infusion and you don't get to see your doctor, even when you're pretty sick. But the good thing with Rahul is that Eric will send him a letter and he'll get back to him.
Yes. And if you were recommending people at UCSF as far as good GU medical oncologists, is Terry Friedlander still the top rank and maybe Agarwal second, or what's your feeling talking to other patients as who the preeminent, GU medical oncologist is in that San Francisco Bay Area now?
It's just hard to say because they've gone. I mean, I mean, when you talk about the San Francisco Bay Area, you're including all the hospitals. So, I like the Kaiser staff of Juan Kim and Andrea Hartstark. That's a good combination over there now. But of course, they're both ex-UCSF people. I think Terry's terrific, and I wouldn't hesitate to recommend him. I mean, if I had to see somebody, that's who I'd ask for there now. I think Agarwal's good. Eric's small, but he's not taking new patients. I frankly haven't looked for a while at who's in the GU medical oncology group. I'll make a note and look later, but I'm sure, I don't know who they've recruited.
No, I understand. Thanks for that.
So, but yeah, I don't have any issue with Friedlander. I think he's really good. He's a good guy too. I mean, he's got a really good way with patients as well. As does Agarwal.
Good. Good. Yep.
Okay. So, Dennis.
Yes, I just had a couple of quick questions or discussion or whatever about that prednisone to dexamethasone switch, and I clicked on that link that was in your letter, Rick, and I got the abstract of the report. I think that's the one that Len was referring to. It was this phase 2 study, I think in Spain somewhere, that was published in the British Journal of Cancer.
Mm-hmm.
And so I tried to find the clinical trial number, and there was 2 of them in there. And the most recent one was completed. The date for completion was January 2017, but there's no results posted. So I don't know where how they got these results from the British Journal of Cancer here. If that's the right study, it was NCT 029-28432 was the study that it looked at. There was an older study that showed some good results too, but this is something that would be definitely applicable to my situation down the road. And so I was trying to gather more information, like, when would there be a phase 3 trial? My doctor is pretty much by the book with stuff, and not going out on a limb with, because I haven't really asked him yet, but that's my sense. I know where he's at. So unless it's the standard of care, probably wouldn't entertain it at this point in time. Of course, my PSA is holding steady, so I'm not really wouldn't be a candidate for this switch at this time. And in the study, they were talking about patients with an AR gain. Are they talking about the ARV7 positive test that you would get from a blood test, or what is?
No, I believe they're referring to the number of copies of the androgen receptor on the cells in the circulating tumor cells. That's different from a variant, which would be a mutation of the androgen receptor. But just if they say AR gain, they're talking about there are now multiple copies of the androgen receptor, more than in a typical cell. Does that make sense?
Yeah, kind of. And then they said for people that have that, the tumors, the DNA did not respond to the switch, whereas patients with AR normal status benefited the most.
Yeah, yeah, I read that also. So, if you ever down the line ever feel like you might need to or might want to make the switch from prednisone to dexamethasone, you might want to make a note to your doctor that maybe he should have an analysis, basically a liquid biopsy, where they'll analyze your circulating tumor cells to see if there is an AR gain or not. On the other hand, you can just make the switch. If it works, great. If it doesn't, nothing lost.
Yeah. Okay. That was just a little confusing to me, and no discussion at all about a phase 3 trial on this thing. So I don't know if this would be kind of a treatment that's off the beaten path or not, without a final approval of it. It's not like it's a new drug. It's just an existing drug, in a different, used in a different way. But.
Right. Yeah, I'm wondering who would be willing to sponsor an expensive phase 3 trial on drugs that are past their patent. Dexamethasone is a very old steroid.
That's what I got when I was taking the taxanes. Yeah.
I mean, I think I could answer that one. I mean, somebody like Janssen would be very interested in doing it because it prolongs the use of the Zytiga.
Yeah.
So, I would say, well, it's possible that, and I could, I could ask I could ask Caroline Pavis if there's any talk about running a prednisone versus dexamethasone trial. You know, here's a question that I'm not sure the answer to, which is, when trials are run in Europe, are they recorded on clinicaltrials.gov if they're not run in the US?
Yes.
I mean, is clinicaltrials.gov worldwide?
I believe it is, because when I looked it up, that's how I knew this was done in Spain, I believe.
Yeah, I think it says that on the I remember seeing that it was done in Spain on the abstract somehow or the other. I don't know how.
Yeah, I went on clinicaltrials.gov, and there was two trials there when you put in prednisone, dexamethasone, Zytiga.
Uh-huh.
So when we were in California, I was talking to Fabio Almeida, and I asked him about the fact that there are very few clinical trials on clinicaltrials.gov that actually have results. And he said, yeah, they're not terribly interested in posting results there. They focus their energy more on publications, as you saw in the British Journal of Cancer.
Mm-hmm.
But it's kind of shocking how few results are actually posted in clinicaltrials.gov.
What was the trial number that you found?
NCT 02928432.
Yeah, that's the same one that I just pulled up.
And there's an older one. There's NCT 01867710.
I haven't found that, but there are a lot. There are 6 or 7 references, academic references, to switching from abiraterone to prednisone, from prednisone to dexamethasone. There are several references, so obviously I haven't looked at all of them, but prednisolone, I think, is what the Europeans call prednisone. I mean, there are several articles, more than just one, and they date back to, because I mean, I know that this is an old discussion. I'm looking at something from the Oncologist in 2015. So there's a bunch of references, but as Len says, I mean, you know, it's not that expensive to switch you from one to the other, and so the doc should be willing to try it. I mean, there is evidence that it works.
Yeah, the older trial had to do with the long-term use of the prednisone being a mineralocorticoid, excess prevention of hypokalemia or hypertension.
Those are common side effects to all steroids, Dennis.
I think they showed less with the dexamethasone.
Mm-hmm.
Oh, okay.
But I know we've talked about, Jake, isn't this, I keep thinking about, your name comes up. Isn't this a discussion that you've had, prednisone versus dexamethasone, or not?
Did you say Jake?
I did. Are you awake?
I'm awake. I don't remember ever bringing it up.
Okay, and I'm probably, then it wasn't you, but somebody I know on this who's a regular on the call has talked to us about dexamethasone versus prednisone before. But again,
okay, I don't want to beat a dead horse the same, but I just trying to understand a little bit better before, I would bring it up if I need to.
Right.
So, okay.
Right.
I kind of ran into a brick wall. I'm going down here and looking up reading as much as I can on the stuff, and all of a sudden, no results posted. So what is this? And what about phase 3 would be the next question. Because my understanding, generally, this stuff has to go through all that. There's a long time, generally, to get new treatments like this approved, I guess, after going through all this.
This is not. The difference here is it's a new protocol, not a new drug.
Yeah.
And that, I think,
different use of it for.
Yeah. And the Zytiga abiraterone is FDA approved, and steroids are. So really, all they're testing is whether it's better, and so it's a sort of a different ball game versus testing out a new drug.
Did we talk about it once, Rick, in years and in months past about using the dexamethasone as an alternative, because then you can take the abiraterone with you don't have to worry so much about the scheduling with food. Was that why we discussed that?
No, that was taking a lower dose prednisone with food.
Okay.
Lower dose Zytiga with food.
Yeah. No, I'm sorry. Yeah, the low dose Zytiga.
Yeah, we certainly talked about low dose Zytiga, but we have talked about dexamethasone as opposed to prednisone in the past.
Mm-hmm.
But I have to defer to my co-moderator who raised this in the first place.
Len?
Me and my big mouth. So what are you referring me to?
We're not. I'm deferring, not referring. I'm deferring to you.
Deferring to me on what?
Where does this go from here? The prednisone, dexamethasone. Where does it go from here? Where does it have to go through FDA approval or before it can be used in this manner?
No, I don't believe so, Dennis. As Rick mentioned, this is just a very slight change in a combination drug. You're going from Zytiga plus one steroid to Zytiga plus another steroid, both of which are approved separately. So a doctor would not need to wait for the FDA to approve this combination for them to administer it. It's just entirely up to them.
Yeah, so dexamethasone is approved for long-term use?
Yeah,
okay.
I
took it short-term when I took the docetaxel, the chemo. That's what they gave me.
Right.
With the chemo.
Right.
That was the steroid. Yeah, so I didn't know that it was approved for long-term use. If it is, that's probably not a big deal.
Yeah, I mean, it's been around for decades.
Okay. I mean, it sounds great. It's everything, PSA goes down more than it would if you were on the prednisone, and then you don't have the other side effects of the hypokalemia and the hypertension possible. So.
And what sounds even better is you staying at less than 0.1. That's what sounds.
Yeah, that's the important thing. But I'm going to keep this in my file of important notes.
Okay. Okay. All right.
Thanks,
guys. All right. Well, you do that. And whatever you do, don't tell us the secret of what gets into your important notes. We don't, keep that close to your chest.
Yeah.
Okay.
All right.
So, Ken Anderson, what's
No,
going on there, Mr. Anderson?
just bouncing around. I haven't been able to stand the whole time, but I'm driving kind of home at the moment. So
I
everything's good.
see. Everything's good. Have you decided when you're going to get your next PSA test?
Yep, on the 17th.
Okay.
So
Okay.
we'll see how it goes.
And what date are you leaving to determine whether the water goes down the plug hole clockwise or anti-clockwise?
I depart on the 23rd.
Okay, 6 days. Okay.
So
Well,
I have the results back on Monday and see whether or not, it was just a one-of. And I'm going to ask them to
yeah.
do a more sensitive test. So
Okay. Good
we'll
idea.
see what they say.
They'll do it. They'll do it. Do you have to get a different? You got some of you guys on the call must know the answer to this. Do you have to get a different prescription if you want a more sensitive test? Nobody knows? Come on.
I don't know the answer. I know that the test, lots of people report their PSA at more decimal points than mine, but
Yeah.
and I think it would be handy to get more. So we'll see.
Yeah. Well, I'm only wondering because if you need to get more decimal points, then you should probably you may have to ask the doc to do it. You don't want to show up on the 17th and they say, oh, we can't do it because we don't have that prescription. So you might want to touch base with Paul or somebody ahead of time.
Gotcha. I'll do that.
Because I'm sure they'll give it to you. But you probably have to, knowing the way that the labs work, they won't do anything unless the doctor's sprinkled holy water.
Right.
So are you ready for your trip down under? Have you taken all the made all the necessary arrangements to cover yourself in business and everything whilst you're away?
Yeah, of course. We're at this time of the year, lots of people are coming into town, so I've been busy. That's what I've been doing this afternoon. But
okay.
It'll be fine. All of them know where I'm going, what I'm up to, and they're just going to come in and go. It'll be one of the first years. Some of them never. Anyway, yeah, they all are pretty handicapped.
Oh, you're talking about your patients, your clients?
Clients.
Oh, really? Okay. Well, I can see them being handicapped without you. That might be a handicap when they come into town.
That's about all. That's what it is. They're just having to talk to anyway. Anyway, I'll get off and finish it up.
Okay. Okay. Well, it's good to hear your voice as always, Ken. Okay.
I need to clear up a myth here, Rick. That toilets don't flush in a different direction in Australia than they do in the Northern Hemisphere.
It's not. Well, wait a minute. This has always been a very important question, both to me and my father, good rest his soul. And I have people who have come back and sworn blind that the toilet goes down, the water goes down the plug hole the opposite way in the Southern Hemisphere.
Probably drunk.
Well, the yes or no.
Oh.
All right, Ken, we're looking for you for the definitive answer.
I'm more worried about driving on the wrong side of the street.
Yeah. Oh, that's easy. I can come down and I'll give you some lessons. Okay. It's actually, that's the funny thing, because for me, I just switch automatically. And I only drove in England for 4 or 5 years before I left. But I don't, And this time was my best ever. I didn't even make, sometimes when I get up first thing in the morning, I suddenly find myself on the wrong side of the street. It's happened 2 or 3 times. This time, no, never did. I was more conscious, but it's not good when you find yourself on the wrong side of the street and there's a car coming towards you. That's not so good. But you'll do fine. You'll do fine. But get yourself an automatic so you don't have to worry about shifting gear with your left hand.
I don't think I can do that. I do actually shift one leg of my journey, so we'll see how that goes. I did not even think about that.
Well, there you go. But I will tell you, don't worry about the pedals. The pedals are still in the pedals. They don't switch the pedals. The accelerator is still accelerator, brake, and then clutch. If you have a stick. Hey, Dennis Correa, have you ever driven on the wrong side of the road?
Not intentionally. I go into a four-wheel drift and guess where I'm on the other side of the road.
I think you do just fine, Dennis. I think you do just fine. Maybe we should send you along with Ken as the other half of the Arizona contingent so that you can report back on the situation with the plug hole and what it's like driving on the other side of the road. I think Len's busy trying to find out which way the water goes.
I already know. I don't need to speculate.
Have you been in Australia?
No, I haven't, but I read about this years ago. It's just a myth. I think the myth comes from the fact that in the northern hemisphere, hurricanes circulate counterclockwise, and in the southern hemisphere, cyclones circulate clockwise. I think that's the genesis of the myth.
I see. Okay. All right. Now, will you accept Ken's word when he comes back?
Yes, I will.
Thank you. Good. Okay. Well, I asked my goddaughter and her husband because they spent 9 months there. It goes down the other way.
All right. Ken, just make sure when you make your observations that you're sober.
No, I am going to be taking some marijuana with me, so I'll try my best.
Okay. All right.
Take a video.
Yeah, take a video. That's right, and send it to Ken, and we'll post it on the site. Send it to Len, and we'll post it on the site. All right. Well, does anyone else? We're still got plenty of time, and we have time for anybody who would like to talk. If you'd like to raise anything that's been on your mind. If not, we could actually finish early. That would be a pleasure. No. I hear no takers.
Motion to adjourn.
Motion to adjourn. I would second that. Yeah. We haven't done this in a long time, but
all in favor.
Some of us are hoping. Yeah, well, some of us are hoping that the Yankees are going to do a little better tonight. So,
yeah, that was brutal last night.
Oh, the worst, the worst. All right, guys, we'll finish up. Jake, I'll let you do the honors to close us out today and close out the recording, and we'll see you next Monday.
Good night, everyone.
Good night, everybody.
Good night. Thanks, guys.